everybody. Welcome to another episode of the Core Consults RX podcast. Cole and AJ, myself, we're here with another accredited episode.
Yes.
Thanks to our friends at freece.com. So, Cole, we are going to be talking about chronic coronary syndrome. Is that correct?
That is correct.
Perfect.
Which is a term that a lot of people probably haven't really heard too much, right?
Yeah, I still
They
have.
kind of switched around the names a little bit.
Yeah, not too long ago. So we're going to talk through some of the basics of this and go through the treatment and kind of the long-term management as well. But if you are a free CE member, then make sure that after you listen to this episode, you go to the link in the show notes and it'll take you to Free CE's website and the post-activity exam for this particular episode. Answer the questions and you'll get your 1 hour of ACPE-Accredited continuing education if you're a pharmacist or a nurse. And if you're not a member of freece.com, you're not an unlimited member, so you can access all their content, including our podcasts, make sure that you check out there are all the different learning opportunities they have, the monographs, the live events, all kinds of stuff. We have a lot of episodes that are accredited now, so make sure you take advantage of it. There's a discount code in the show notes as well that you can use off your annual membership fee, but definitely check out freece.com's unlimited membership. And thanks to them for, again, partnering with us. And with that being said, and before we even get started on the content, AJ, how are you, sir? How's your third year in pharmacy school going?
It's going.
Yeah?
It's going so close, but so far away.
Do you? When do you start picking rotations and stuff for the spin?
I'm already supposed to have picked them.
Okay. So do you not get to
So
pick
you're going to get
anymore?
the last picks?
Definitely.
Oh, jeez.
So you're literally just letting the spin choose for you.
Bottom of the barrel.
Wow.
It's like
That's
the
daring.
total opposite of what I would want to do.
So is that on purpose, or was that just because you lost track of time? And
Adversity, man. It just can make me a better pharmacist, and I really like the challenge. That was the plan.
so what's the real answer?
I forgot.
Okay, I thought so. I
Just going to start listing all the bad rotations you're going to have
all
that I can just see.
I will say I give you credit for trying to put a positive spin on it. I like that. That's good. Yeah, I definitely was a little more strategic with my rotation selection.
Yeah, which I guess you can only be so strategic because the way they do it at our school, Mike mentioned the spin, but you kind of put preferences and then they
Then they don't take any of them into account. And they just
right,
give
they
you a
spin
random
it out.
one.
It's like bingo, you know.
Yeah.
B1 is this AMCare rotation.
So
Y4 is this acute care rotation.
yeah. And if you don't pick like AJ, you probably just end up with nothing but horrible acute cares that he's going to spend nothing but 80 hours a week in the hospital.
Pediatric neuro ICU for 7 months.
There you go. See, you'd be an expert.
You'll be an expert.
But yeah, so I don't miss those days.
You gonna
But
dress up for Halloween, AJ?
That's the plan. Me and my dog have matching.
What are you gonna be?
Just overalls. That's it. No
Just overalls?
costume. Yeah.
your big Doberman has overalls.
Yeah.
That's pretty amazing.
Is Jackson dressing up?
Probably.
Got a
I don't know.
costume?
She has like pumpkin pajamas for him or something like that. So
Okay.
I don't know if that's the height. He may have other plans. I don't know.
Nathan was a pumpkin. His
Was
first
he?
year.
Oh, perfect. There you
Yeah.
go. So it works.
It's gonna be a giraffe this year.
Perfect.
Yeah,
What are you gonna do for the long neck?
it's genetic, so
That's
it runs
good.
in the family.
That's good.
Yeah, I should have done like a Star Wars character or something, but wife went with
Missed
it is
opportunity.
a missed opportunity.
Next year, we'll do it.
Baby Yoda. Oh,
Maybe
Grogu?
There you
Yeah,
go. See,
golly.
we're nerds.
yeah.
I was Jar Jar.
It's a good character. All right. So let's jump into this, talking about chronic coronary syndrome. So typically when we talk about this, or that kind of terminology, we're talking about acute coronary syndrome. And, that is something that we've gone over in the past, but this chronic coronary syndrome is basically sort of the new terminology when we're talking about what was once like stable ischemic heart disease.
Or chronic stable angina. Is that the same?
Yeah,
thing?
that's the other kind of term for it. There's a bunch of different names that have kind of gone,
Yeah.
ischemic disease, whatever. But chronic coronary syndrome is more of the acute, or the chronic long-term management of, a patient that has basically underlying CAD, coronary artery disease, that is resulting in angina and, some of those types of symptoms.
And I think that part of the reason they changed the term, other than just wanting to confuse people, is some people's angina is not perfectly reproducible and predictable. It can be kind of sometimes all over the place and still be considered chronic coronary syndrome. And so it's more of an umbrella term to capture that.
Yeah.
At least that's what I read.
I think that's why they're referred to as syndromes as well, so it's plural.
It doesn't always fit into the box that maybe you would think of when you hear chronic stable angina or something.
So coronary artery disease, kind of the underlying, disease state, is the buildup of atherosclerotic plaque that's basically accumulating in the coronary arteries. So you can sometimes break it down into obstructive, non-obstructive. I believe it's greater than 50% of stenosis would equal obstructive. But the patient can have sort of like these long, like stable periods where the disease doesn't really progress, or at least progresses slowly without being symptomatic, and then they can quickly become unstable. Whereas if some of the plaque were to rupture and cause an acute thrombic event,
Right.
that would potentially lead them to an acute coronary syndrome
Right.
event, which is then broken down STEMI, unstable angina. So we're not talking about in the emergency situation, although sometimes obviously the chest pain portion is a big focus of this in general. And so acute or chronic can both have that angina present, that chest pain, so that they can kind of start off looking similar, hopefully, with the chronic, though it typically is resolved with treatment, and those events become less and less with more maintenance therapy.
Right. Broken down, coronary artery disease is broken down into what Mike was talking about, ACS, and then chronic coronary syndrome. Patients with suspected coronary artery disease and stable anginal symptoms and or dyspnea. So that's another thing that's kind of captured under the chronic coronary syndrome, is not necessarily classic angina signs, but they might have dyspnea on exertion, and it still be related to chronic coronary syndrome. Also, patients with new onset heart failure or left ventricular dysfunction and suspected coronary artery disease can fall into this category. Asymptomatic and symptomatic patients with stabilized symptoms 1 year after initial diagnosis or revascularization, and asymptomatic subjects in whom coronary artery disease is detected at screening. So there are some things they can do to screen and confirm that they have coronary artery disease.
Yeah. So we're going to be talking about angina and kind of some ways to prevent that from happening to the patients who have this. But it's really, sort of a result of increased myocardial oxygen demand, and then having a fixed decrease in the myocardial oxygen supply. So basically speaking, the oxygen is not able to travel through the blood as readily as it once was because of that atherosclerotic buildup, and so the lower oxygen levels leads to the feeling of chest pain that patients will describe. So everything that we're doing is hoping to decrease the risk of kind of moving things and progressing forward, cutting down on the plaque buildup, so lipid controls, things like that. Smoking cessation becomes a factor long term, but then actually treating the angina and basically opening up those arteries to allow that blood flow more readily and take away any other factors that could be attributing to that myocardial oxygen demand or supply. So that's going to be kind of the mechanism in which we're trying to go about reducing the risk of patients experiencing this angina on a daily basis, and a lot of our management revolves around that.
Right. And like Mike said, if the plaque ruptures, leads to a thrombus formation, coronary blood flow will rapidly reduce, and that's a medical emergency. That's acute coronary syndrome. There's also something called vasospastic angina, or Prinzmetal angina, variant angina. And this is chest pain due to vasospasm of the coronary arteries. And it can occur at rest, so it's not usually associated with an underlying coronary artery disease. It's not something you would do a stress test for to necessarily reproduce. And that is important because there are some medications that you don't want to use in vasospastic angina that are standard for chronic coronary syndrome.
Yep. So I guess let's just start off with chest pain in general. So even in an acute setting, there's some things we want to kind of establish, based on the patient or their family member's responses, to the situation at hand, or, if they're first having, approaching care for this, if they're not having an angina attack at that moment. So basically, we want to figure out like the onset and the duration. So did the symptoms sort of gradually build in intensity over like a few minute period? Was there like this sudden onset? Do they have radiating, to the upper, lower back? Is it something that is sort of like a fleeting chest pain for a few second durations and then, maybe not actually associated with any type of ischemia. The location and radiation of the actual pain itself, the severity, obviously the other precipitating factors. So like, were you just resting? Were you under emotional stress? Were you doing some kind of physical exercise? Those types of things. Obviously, like occurrence at rest might lead you more to a vasospastic angina type of thing. But positional changes can also change things. If it's like a positional chest pain, or they could be from non-ischemic origin, like some kind of musculoskeletal issue or something like that. And then what actually helped to relieve the angina symptoms if the patient has access to anything, so nitroglycerin or something like that. It's not like necessarily diagnostic, but it is at least another clue.
Right.
And then, any kind of other symptoms as far as frequency or having them describe the pain. There's a really good, diagram, I guess it's very simplistic on I think this is the American Heart Association guidelines from 2021. AJ, will you show my screen real quick? This, diagram here just shows basically the high probability of ischemia, more of a central pressure, squeezing, gripping sensation or heaviness, tightness, left-sided, dull, aching. Those are all things that are more higher probability of being ischemia versus like a sharp, fleeting, shifting, positional type pain, ripping, burning sensations more on the lower probability side. So it's a very simple way of looking at it based on like commonly used descriptors of patients that, typically will throw at you.
And so that is kind of how you can help gauge whether it's related to ischemia or not. But of course, when somebody goes into the ER and complains of chest pain, it's like, you're going to go to the front of the line because it could be something really bad, like an MI or acute coronary syndrome, or it could be something that is not necessarily an emergency, like chronic coronary syndrome. But there's a whole host of things that have issues that could be related to chest pain. So some of that differential that they have to work out is, of course, whether it's an acute coronary syndrome, and there's kind of clinical findings that you can see on physical exam that would point you in one direction or another. Acute coronary syndrome might have sweating, increased breathing, increased heart rate. Also, they'd have to work through whether it could be a PE, an aortic dissection, esophageal rupture, pericarditis, myocarditis, some sort of pneumonia or pneumothorax. It could even be herpes that was having pain radiating in the chest or something like that. So there's costochondritis. So there's a number of things that it could be that they have to work through to determine whether it's an emergent situation or just something that is more chronic like this.
Yeah. So like, for example, if they're having chest pain, but they're also having, fever and issues like that, especially increase in the, in the pain and in the supine position, things like that, that may be more of like a pericarditis or myocarditis type of thing. So like little nuances can kind of lead you in one path or the other. But really the first thing after the history and the physical exam that you'd want to obtain is an ECG, however you want to say it. We were just talking about this before we started recording of how we all say it. I do historically use EKG still, even though technically ECG is proper.
Yeah.
Let me guess, AJ, you say it the right way.
I do.
Okay, I figure.
Because he's a young man.
Yeah.
He hadn't been around.
He's not as burned out and jaded as Cole and myself.
But though we are updating our vernacular with chronic coronary syndrome.
So there you go. Look at us go.
We can do it.
See, AJ?
Halfway there.
You doubted us. Now we just got to get our other terminology right. So ECG, because obviously you're trying to establish whether or not if they are having an acute coronary syndrome, and that's what's causing the chest pain, then it could be a STEMI, NSTEMI, something along those lines, which we would follow those guidelines if that was the case, or it could be some sort of like new arrhythmia, which we would have to manage depending on what type it was. If it was a normal EKG, or just basically something that wasn't diagnostic in any way, we would basically want to repeat that if the symptoms persisted, or if the next step would be getting the troponin levels, and if the chest pain's not going away, and if those show that there's an increase or a positive troponin level, then we would probably want to continue to repeat that EKG until something shows up if it does.
Yeah, and if it is acute chest pain, like he said, and we do an ECG, we have to determine the cause. If we don't think it's cardiac related, then there's a different path you go down. If we think it is, then if it's acute, that would be a STEMI. So you'd want to follow this, or it could be a STEMI, so you'd want to follow the STEMI guidelines. If not, there's other things. Acute coronary syndrome that's not a STEMI, acute aortic syndrome, PE, acute myopericarditis, valvular heart disease, that sort of thing.
And also that kind of goes back to some like kind of tying in all the physical and history and whatnot back into what those findings show. And that obviously can continue down the path of the differential diagnosis.
Right.
So, the new 2021 guidelines from American Heart Association are basically providing you with these like sort of algorithms, these flow charts of how to handle these acute situations. Because initially, if there's possible ACS, then you have to handle, looking at the risk of, whether or not you need to do further testing, or if you need to go, if it's a high risk patient, you might need to go and do invasive coronary angiography to make sure that, they are not having an actual event in that moment. And if not, then I can, maybe discharge you and have them just follow up. But, if the patient has, no established CAD, then, if some of those initial tests coming through, like Cole was saying, you can actually have a diagnosis of where they get to the point with their chronic coronary syndrome. They can do various tests to kind of look for, other signs. There's a whole flow chart basically. AJ, show my screen real quick because I don't want to go through all this because this is not our area of expertise, but this is one example of how many steps that are involved in the algorithm. I know it's probably hard to see, but that gives you an idea. So it's very, very thorough, I would say, and kind of walks you through all the different potential options for imaging and, whether or not you're going to do like a stress testing versus a coronary CT angiography or, invasive angiography at some point. So check that out in the new guidelines. There's a lot of really good charts that are worth hanging on to.
And the coronary CT angiography is the non-invasive.
Mm-hmm.
Is that the non-invasive one? Okay. So they kind of, with imaging, if they're going to, or with testing, a lot of times they're deciding between the two non-invasive options, which is the coronary CT angiography or the use of stress imaging. And then if they aren't really getting what they want from that, or they're not lining up from what they suspect, and they might have to go an invasive route. When you're determining which one to do, generally between the two, there isn't any like difference in mortality by using the one versus the other, and the coronary CT angiography is generally considered more expensive. So in that sense, the stress imaging might be better. But it just kind of depends on where you're at, what the physicians are familiar with, what technology they have available to them. There's stress testing with, putting them on a treadmill and having them walk, and that's kind of what you are familiar with and you hear a lot of people talk about. There's also pharmacologic stress testing for a patient who can't physically do that. They can, if it's safe to do so, they can get the medication to get their heart rate to a point where they could induce angina and make it reproducible. But it also depends on what your goal is. If you're looking to rule out obstructive coronary artery disease or detect a non-obstructive coronary artery disease, the CCTA might be better. For ischemia-guided management, the stress imaging might be better. And like I said, the availability and what the physicians are used to, their age might play a role. So if they're over 65, then there's a higher likelihood of obstructive CAD, so stress imaging might be better. Under 65, it's less likely, so CCTA might be better. And then prior tests that they've had, if they have other indications for using one or the other, like anomalies in the coronary arteries or suspected coronary microvascular dysfunction, it might point you one way or another. So just know that those different tests are out there.
And then the other thing you'd want to do, and again, this is potentially in an acute setting where you're not really sure what's going on, or you're suspecting the patient might have coronary artery disease and chronic coronary syndromes, but getting patients, CBC, their CMP, so you can check their renal function, getting a lipid profile, an A1C, thyroid panel, all those things are going to be good and can help sort of lay out your long-term maintenance plan for the patient.
Yeah. In long term, there's two real treatment goals. So the first is to slow the progression of the atherosclerosis, if that is present, and prevent complications, long-term complications like heart attack, heart failure, stroke, mortality, of course. We can do this through risk factor modification, medications to reduce the risks of further vascular damage. So we'll kind of talk through some of the specifics on that, but treating other diseases that can increase cardiac risk or lifestyle changes, that sort of thing. The other is to reduce the number of ischemic episodes and increase the amount of exertion or exercise the patient can accomplish before the chest pain occurs. So a lot of the medications we'll talk about for this by treating the angina, we're not necessarily providing any mortality benefit. It's more of a quality of life thing. But we still want to reduce the number of episodes, and I guess it's more for quality of life. We want to reduce the number of episodes and then increase the amount of things that they're able to do, while also treating underlying conditions that could progress the atherosclerosis and then lead to one of those negative events long term, if that makes sense.
Yeah, and I mean, at the same time too, like sometimes treating the angina, depending on the agent you're using, depending on their comorbidities and stuff, they can potentially
It definitely can,
risk,
especially if there's other things going on. I guess like strictly like a beta blocker for angina doesn't necessarily reduce mortality, but if there's previous MI or something like that, then of course it definitely could.
All right, so some kind of risk factor modifications that patients can do in long-term, medications and whatnot. Obviously, the physical activity, weight management are always big. If the patient has any sort of issues with, being overweight or obesity or anything, lowering weight can definitely decrease cardiovascular risk all around. Physical activity always is beneficial for various disease states. Having them meet with an actual dietitian is definitely a good option potentially if, they've never been kind of educated on proper dieting and healthy eating. Usually we're going to use statin therapy for our lipid management, depending on what other risk factors they have, what their ASCVD risk is, if they've actually had an established event or anything like that. That's going to obviously change which statin we would use and which intensity and whatnot. But, a Torva or a Rasuva, either moderate or high intensity, depending on the situation, is usually first line. And then from there, you would potentially add ezetimibe and then maybe even a PCSK9 inhibitor, again, depending on what all the risk factors are and what's going on with the patient. From a blood pressure management standpoint, we typically want to get these patients under 130/80, just like most other disease states nowadays. And again, like we've kind of touched on, depending on what medications you're utilizing for the angina, maybe that can be beneficial for the blood pressure as well. But regardless, we need to get the blood pressure down to that goal measurement as long as the patient can tolerate it. And then if they do have diabetes, getting their A1C under control, ideally less than 7, but depending on the patient, their age and all that, might be a little bit more lenient.
Yeah. So this would be an instance where you might see a patient on like lisinopril and then metoprolol, and you're like, they shouldn't have been on metoprolol second line for blood pressure. Well, they're not. They're using metoprolol to treat their angina. You know what I mean? But before we get into the beta blockers, nitrates are a mainstay of angina treatment, acute, and maybe not first line, but are also used to prevent angina as well. Have you ever seen somebody have a heart attack before? Neither have I. But what you know with the nitrates is the little amber vials of the nitroglycerin and the little sublingual tablets. Like they come in packs of 100 and nobody knows how to bill to the insurance correctly. That's what you're familiar with people carrying those around in their pocket. And a lot of, I guess I should say up-to-date. Up-to-date recommends anyone with angina having those, like they prescribe them for everybody to treat the acute episodes. And interestingly, to prevent episodes, if they're doing, if there's some activity that they're about to do that they know causes angina, they might say go ahead and take one before that, which I wasn't super familiar with that, and they even comment that a lot of people aren't, because usually it's used when they are having symptoms, they take it, but it can be used right before too. So what they do, nitrates, they reduce myocardial oxygen demand, they decrease preload, and they increase oxygen supply by increasing blood flow. So there are instances where you definitely would not want to use them. We know with the PDE5 inhibitors, Viagra, and Cialis, contraindicated. It can be very dangerous, so don't use those together. Otherwise, it can cause hypotension, headache, and then a nitrate tolerance. So this isn't as much of an issue with the sublingual ones that you're using acutely, but with the daily medications, the daily nitrates that you take, we'll talk about it more specifically, but you can have tachyphylaxis where you get a tolerance to the nitrate and it's not working as well. Otherwise, it can cause fainting and flushing and lightheadedness, but for the most part, it's reasonably well tolerated.
Yeah, especially in the as needed setting.
Yes. Yeah.
And we got a few different options for like as needed short acting nitrates. So we have typically it's going to be a nitroglycerin based medication, but we have the sublingual tablets like Cole was just talking about. So that's like the nitrostat. But they also have like a sublingual spray called Nitro Mist if you're trying to be fancy. And then they even have a Go Nitro, which is probably the lamest name ever.
Really?
But,
I thought it was kinda cool.
Sublingual powder. That,
Reminds me
you
of
can
that.
use.
The powder. It reminds me of that. What was that energy drink that was blue with the orange letters?
I have no idea.
All right, I'll think
AJ?
of it. It has something to do with nitro.
NOS.
NOS.
I think it's
NOS.
just called nitrous or something.
It's called NOS.
Yeah, nitric oxide or whatever. Or is it just
Oh, I guess
NOS?
that's what it stands for.
But because now you say that, the security guard at my old clinic used to drink those all the time. So,
Really?
we would always see that in his bottle, NOS.
It did probably stand for nitric oxide, but I looked at it as a high schooler and saw NOS.
That is what NOS stands for, right?
Well, as a high schooler, I didn't know that.
From Fast and the Furious, is that what you heard NOS of or NOS before? That's like where that term started.
Not a
everybody
big
started-
Fast and Furious guy.
Oh, good. It's not. They're not good. I'm just saying, like that's where typically people are talking about NOS.
Maybe
from.
I saw the first one, but I haven't seen number 9.
Oh, that won the Academy Award for best movie ever made. So we have those options for short acting nitrates. Like Cole was saying, this is like an as needed type of thing when they need like immediate relief from chest pain. So first signs of chest pain, the patient takes a dose. After the first dose, if they're still having chest pain, they're going to start calling 911 to make sure you get EMS on the way. You wait 5 minutes after the first one, you give a second dose, you can wait 5 more minutes and then take a third dose, but you're not supposed to take more than 3 doses within 15 minutes, at least not in a medical setting. So, that's kind of the instructions to give patients. Hopefully EMS is going to be getting there soon after and can start the process of escorting the patient to the hospital if the pain is still happening, if they're, that's where you may be suspecting more of an acute situation. And then, like Cole said, you can take them 5 to 10 minutes kind of before activities that start that is known to cause that angina in the first place.
Right. So if you've ever wondered why they're in those little teeny amber vials, you do need to keep them in that original container. And the reason is it can interact with plastic and lose potency when exposed to light. So that's why they're in that dark glass container. You also don't want to store them in not only a plastic vial, but a vial with a child safety cap, because during an episode of angina, you don't want them having to struggle to open the safety cap, which is funny because those little the little nitrostat amber vials are so small.
Yeah.
Anybody without like fine motor dexterity would not be able to quickly open one of those, even though it's not child resistant.
Well, and then getting the tablets out, you just dump them all in
I
your
know.
hand.
It's
and
just like,
pick one.
it's
Yeah.
very high likelihood that you're just going to be like, screw it, and just throw them all in your mouth.
Yeah, they're very small. Those bottles are small.
I guess it's for cost and convenience, like
Travel.
transportation. Yeah, but man, they're teeny tablets.
Put some fillers in there so you can get a bigger tablet.
I know. Also, don't store them in the bathroom. As you can imagine, the moisture could be an issue with the sublingual tabs. Keep them close to you, in your chest pocket if you have one, or your purse or whatever. Ideally, patients are sitting down while they're taking it because of some of the side effects they could have. You wouldn't want them to pass out and that sort of thing. Also, it's important just to counsel the patient how to use a sublingual tablet if they're not familiar with it. So it's administered to be under the tongue to provide rapid absorption and it avoids first pass metabolism. But they would need to keep it under the tongue until dissolved. So just to explain that. Once open, the tablets are only good for 6 months. So if more than likely they're not going to use all 100 of them. Is it 100 or 25?
They come in 25.
25, yeah.
But that's a good. I'm glad just to take a quick, interjection here. Because the little package they come in has 4 of those 25
That's what I'm
bottles.
confused by. Yeah.
But the reason for that, because a lot of times they just write for 25,
Yeah.
and then you pull one of those out of there and give it to the patient.
Yeah.
But they're in that 4 count because they ideally want the patient to have one at home, one at work, one somewhere else, in the whatever, not in the
Yeah.
car, but you know what I mean.
Yeah.
Somewhere where they may be traveling with them, so they always have them available. So that's why they're actually. Ideally, you want to write it for 100 at a time and then just get new ones. They're generic. They're not expensive.
It's been a while since I've been dispensing, but I knew I had 100 in my mind for some reason. So yeah,
Still got it.
if they're not using all of those in 6 months, which they very well may not, then they should need a refill just because of the shelf life. The spray is good for 3 years. There is a cotton plug in the bottle that you wouldn't want to really have to deal with right before, as you're having an angina attack, so you want to take that out. Yeah, Mike mentioned calling 911 and that you can take it 5 to 10 minutes before an event's coming. So those are all just good educational points for the patients, that they may not always get.
Yeah. I've seen some of those bottles of nitroglycerin that look like they were purchased 17 years ago.
I know.
And
In 1945.
I haven't had to use these in a while. I'm like, well, that's a good thing. I don't think they're going to work very much.
Don't shake that bottle too hard because it'll explode. That's how old it is.
Not work for you.
Don't put that in the back of a cart in a Western.
All right, so short-acting nitrates are our PRN solution for acute chest pain the patient may be having outpatient setting. But we ultimately want to give medications that can reduce the risk of them having those events in the first place, so hopefully they're not having to use their nitroglycerin sublingually. So the first class of meds we'll talk about is our beta blockers. Cole already mentioned these, but this is sort of like the first-line agents for a lot of patients. From a mechanism standpoint, obviously we're reducing myocardial oxygen demand because you're reducing that heart rate. You're reducing contractility, left ventricular wall tension as well. And so overall, that oxygen demand is going to go way down. Basically, the onset of angina, or what they would refer to as like the ischemic threshold during exercise, is often like delayed or avoided completely with patients on beta blockers as well. So they can help with quality of life and as well as just sort of like reducing the risk of them having an angina. All types of beta blockers do tend to be seen as kind of equally effective when it comes to angina. However, it is very important to make sure the patient doesn't have vasospastic angina. I know Cole kind of alluded to this earlier, or Prinzmental angina, whatever you want to call it. But in those patients, beta blockers are not going to be effective, and they actually can increase the tendency to induce a coronary vasospasm because you're having like unopposed alpha activity. So unless you're using like a carvedilol or something, that risk of alpha receptor activity can then throw off the effects, cause a vasospasm, make the angina worse for those patients. So it has to be, non-vasospastic, regular, just standard angina from chronic coronary syndromes that would be beta blocker approved. You also got to keep in mind when we got to titrate the dose slow, start low, go slow, that whole thing with beta blockers, that's still in play here because we don't want to induce side effects. If the patient is going to stop them for whatever reason, whether it be side effects or what have you, you got to taper the patient off. If you just stop it immediately, abrupt discontinuation is going to cause rebound angina. And so, the symptoms are going to come right back. We want to have patients' heart rate being monitored. And so if it's somebody who has, pretty severe angina, maybe 50 to 60, maybe even lower beats per minute would be our goal for those patients. And then as long as you can get the patients, in most patients, their exercise heart rate to less than 100, then you're going to get the vast majority of patients that are having, angina during an exercise session. So again, lowering that heart rate pretty significantly, depending on what their baseline is, but that can help pretty tremendously with symptoms overall.
If y'all heard any background noise, it's because we just had a 737 fly over the studio. We do happen to live close to an airport, but it's not often that we hear a plane pretty significantly fly over, right?
So usually they like 2 a.m. and stuff, they'll do it. Like one of our old neighbors actually used to. He was in the Air Force, but he would like fly with like the special, or like take the special forces guys. So he was like some part of some special unit or whatever. And so they would have to practice really low, like flying in those big planes. And so you'd hear him just ripping to the sky at like 2 a.m. And I was like, hey man, you guys doing drills last night? He's like, yeah. So I guess the air base is right there. So they do.
Yeah, we have the Charleston International Airport, and we have the Air Force base. We also have a naval base, all right around here.
So much stuff here.
Oh, speaking of that, it makes you kind of nervous when you hear it now because there's all the talk about nuclear stuff, and then they put out like who's more likely to get hit by a nuclear bomb.
Oh yeah,
and it's not like the big cities like New York and stuff. It's people who are close to like power plants, but also people who are close to military installations.
Right.
So we have an airport and then 2 military installations right here.
Right.
So
yeah, it's fantastic.
I know. we're on the chopping block.
So that's good news.
Yes, that's beta blockers. So calcium channel blockers. That's another option, and the guidelines say beta blocker or calcium channel blocker. I think a lot of people would go with beta blocker first. But if they had a reason they couldn't use a beta blocker or contraindication, calcium channel blocker is a reasonable option. They improve anginal symptomology by causing coronary and peripheral vasodilation. They also reduce contractility. Long-acting diltiazem, specifically long-acting, or verapamil, or a second gen, which would be the dihydropyridines, amlodipine, extended-release nifedipine. Those are the preferred calcium channel blockers to use. They can be used in combination with beta blockers when initial treatment is not successful, or if you can't use a beta blocker, like I said, for contraindication or side effects, then that's when a calcium channel blocker would come in. If they have vasospastic angina and we can't use a calcium channel blocker would be the preferred agent in Prince metal angina.
There's also, when it comes to the non-dihydro agents, there's some data, like for example with verapamil compared to atenolol in patients that had CAD. There was fewer adverse outcomes with verapamil compared to atenolol, which we all know atenolol is not our favorite anyway as far as beta blockers go, but that's usually more in a hypertension standpoint. But verapamil is associated with less cases of diabetes, so some of the beta blockers have actually been known to cause metabolic issues and lipid increases, things like that. And so verapamil was better in that regard. Fewer anginal attacks just numerically, which that's kind of interesting. And then also, just other side effects were less associated with verapamil compared to atenolol. That being said, diltiazem also has some advantages even compared to verapamil and may be a better option. So it has the peripheral vasodilation and the relief of exercise-induced coronary constriction, all that good stuff. But the outcome studies comparing diltiazem or verapamil have never really been done. That being said, though, that it does seem that diltiazem is a little bit better tolerated, doesn't have the same GI effects as verapamil does, and it still is going to be very effective potentially. And if you do have to use a beta blocker and a non-dihydro protein calcium channel blocker together for whatever reason, maybe the beta blocker is not doing enough on its own and the patient's heart rate's still high, whatever, you have to be very close monitoring, but diltiazem would be the one to use in that case. And then with nifedipine, there's long-acting nifedipine. That's one that has been looked at a little bit in this patient population, but really it's not really been seen to improve like survival or anything like that. Amlodipine, again, probably because of its really long half-life, does actually seem to be one of the best options for patients with CCS, especially if you need some reducing of the blood pressure as well, or patients who have vasospastic angina as well. But there's been plenty of studies that have even compared like adding a calcium channel blocker like amlodipine to a beta blocker, even at first line. So we'll kind of talk about that after we've gone through everything, but just to kind of narrow it down a little bit more, the amlodipine or diltiazem, depending on non or dihydros that you need, just to give you some more context.
We also have a Boeing plant right here. I think we'd be in trouble. I have a lot of friends who work there.
Yeah, I hope not. I feel like you're going to really jinx us here.
I don't know. I just started to think about it. I'm like, man, I think
we're having a full-on panic attack in the podcast.
Fortunately, we're on like this side, but anyways.
Yeah.
No, I'm not worried. So I referenced the long-acting nitrates and the tachyphylaxis. So there's a number of options we have for long-acting nitrates that you would use to prevent anginal symptoms, not the sublingual or the spray to use acutely. We have nitrobid, which is actually nitroglycerin ointment. This is an interesting one, right? So it comes with a measuring applicator supplied with the tube of ointment. You spread the ointment using the dose applicator lightly onto the chest. You don't rub it into the skin. But yeah, you can use an ointment and have it absorbed transdermally, kind of locally to work. You can have more of a systemic transdermal patch, which is branded as NitroDur, and that's nitroglycerin transdermal patch. You have to, because of the tachyphylaxis, you wear it for 12 to 14 hours, but then you have to remember to take it off for 10 to 12 hours. Probably a tough thing to remember for that reason. People definitely use it. I feel like I see VA individuals use it. Patients use it like a lot more than others, but for that reason, adherence can be an issue, just remembering to take it off. So the once a day or twice a day medications might be a little bit easier there.
Maybe it's not formulated with TRICARE or something.
It must be or something. Also, like the clonidine patch.
Yeah, really?
Yeah, with VA patients.
They like their transdermal stuff.
I guess
for adherence.
It was like the only patients I'd ever see on clonidine patches.
Yeah, maybe.
I don't know. What is clonidine used for though? The hypertensive crisis, but that wouldn't have to do with a patch, right?
No, I think I've seen them use it for like if they're using it just to like calm down like patients who are having like anxiety and things like that. Because it's like kind of like a central or alpha 2 agonist,
PTSD, anxiety sort of thing.
Yeah, but I've also seen people use the patches for like just hypertension.
Yeah,
I guess for adherence, because usually clonidine you're taking it 2-3 times a day orally. So I'm assuming that's what it is for the adherence piece. But obviously clonidine's not a good option anyway. So
interesting. I always wondered about that. So the ointment, also kind of a unusual one. So the patch and the ointment, I don't know.
And you have to use the applicator too, because that obviously gets absorbed in the fingers.
Right.
One of the off-label uses for that ointment is like Raynaud's phenomenon. So like you'll apply it to like 1 or 2 fingers and it opens up the blood vessels so that you're not having the constriction and rapid dilation that you'd get with Raynaud's typically. So you definitely want to use the applicator.
So those are there. And I guess they're used. I mean, I did see both of them, but much more commonly, you'd probably see the oral options. So there's isosorbide mononitrate and dinitrate. There's immediate release and extended release versions. I think the extended release versions are generally preferred for ease of dosing. You have to dose them kind of specifically so that you get the nitrate-free period. It also depends on when the angina is happening. So some people have angina on exertion throughout the day, and so you'd want to dose them during the day and then have the nitrate-free period at night. But some people have nocturnal angina. And if that was the case, then you'd want to dose them at night, or at least take them before bedtime, and then have your nitrate-free period be most of the day. Same with the patches. You might have to sleep with the patch on in that instance and then remove it for a nitrate-free period during the day. So they're a little bit complicated. For that reason, they're not considered first line for prevention. You would go with metoprolol, probably beta blocker, then calcium channel blocker. Then you could add this on or have this as a third line option.
And with nitrates, basically, with prolonged use, you're getting this reduced bioactivity, basically, of nitric oxide, and you also activate the RAS system. So you're getting vasoconstriction as sort of like a response to that nitrate-induced vasodilation. And so, with like Cole was saying, with the intermittent like kind of therapy, the nitrate-free interval, you allow your body to kind of have this regeneration of what they call reduced sulfhydryl groups, which are involved with the nitrate to begin with, and then that restores the vascular responsiveness to the nitrate by having that free interval. There's another medication as well that is kind of in its own class, so to speak. Renazoline, Renexa is the brand name. And it's decreasing myocardial oxygen demand, basically by decreasing the ventricular tension and oxygen consumption overall. One of the nuances with this medication, though, is it can cause QT prolongation, so that's a concern. It also is not supposed to be used used with severe caution because it can cause acute renal failure in patients that have a creatinine clearance less than 30 mils per minute. Some other kind of adverse effects: dizziness, headache, constipation, nausea. Can be used, as an add-on or in place of beta blockers or calcium channel blockers or whatever, or add-on therapy, depending on if those haven't worked. One of the good things with the Renexa is that it doesn't have too much of an effect on heart rate or blood pressure. And so if the patient's blood pressure, heart rate are keeping them from being able to use calcium channel blockers or nitrates, whatever, then this may be a good option in those patients. Yeah. It is a CYP3A4 substrate, so it's really only a big deal when you have strong 3A4 inhibitors or inducers, but kind of keep that in mind, especially with like the QT prolongation risk and things like that.
Yep. So in the guideline, there's a really great table kind of summarizing and also giving situations where you would or wouldn't use certain things, and it kind of gives you a stepwise look at it. Mike mentioned that he gets a lot of questions about this from his students, but basically, as needed, we have the short-acting nitrates, right? Then first line, we're going to have the beta blocker, calcium channel blocker in a regular situation. But then there's other situations where you might choose one over the other as far as non-dihydropyridine, dihydropyridine, calcium channel blockers, or maybe a beta blocker. So if their heart rate is greater than 80, you could go with a beta blocker or probably a non-dihydropyridine calcium channel blocker in that instance because of its negative chronotropic effect. The heart rate is less than 50. You might choose the dihydropyridines because it doesn't have as much or any effect on heart rate. If they have left ventricular systolic or left ventricular dysfunction or heart failure, beta blocker, of course, and might as well go with an evidence-based beta blocker in that instance for heart failure. And then if their blood pressure is low and you're having trouble with that, low dose beta blocker, low dose non-dihydropyridine calcium channel blocker, because it's going to have less effects on blood pressure. Probably not choosing carvedilol in that instance.
Yeah,
right?
exactly.
And then there's others. So second line, standardly, beta blocker or dihydropyridine. And it kind of follows the same algorithm, but then second line, if their heart rate's less than 50, you would probably go with a long-acting nitrate in that instance. If they have left ventricular dysfunction, you have to add on an extra medication to the beta blocker, long-acting nitrate, or possibly ivabradine in that instance.
Yeah, there is some data from like the beautiful trial and a couple of with ivabradine looking at occurrence of angina and ACS and things. So there is some data in patients that have like that as an underlying condition, and you may be trying to avoid the patient from having blood pressure drops or issues with hospitalization due to heart failure, that side of things. Then you can add on ivabradine. There's probably other better options as well, but since it has had some data, the European guidelines included it in there. Plus ivabradine's been approved in Europe for way longer, so that's probably why they're a lot more comfortable with it.
Right.
Just reiterating something too, when Cole mentioned the beta blocker or the calcium channel blocker as standard therapy, there are potential situations where you may even combine beta blocker and calcium channel blocker right off from the beginning. In much more rare cases, you may do a beta blocker and non-dihydro together at the beginning, but you'd have to be super careful, a lot of very close monitoring, low doses, very low, slow titrations. It'd be a lot easier and probably more beneficial to the patient overall if you did the beta blocker plus like an amlodipine or nifedipine ER instead of the non-dihydros. And then if the heart rate is still above 80 when you actually do the combo, that would kind of indicate an okay situation to do either or, either types of calcium channel blocker. But if it's less than 50, you're having to start off with just the dihydros like calcium was, like Cole was saying. So amlodipine, felodipine, and then instead of being able to switch to beta blocker or anything else, you have to jump right or switch right to the long-acting nitrate or add it to it. So it kind of takes away a lot of your options. But most patients, their heart rate is not going to be that low unless they're like a sprinter or something.
Right.
But kind of one of our last line options, and is usually a good add-on, would be the Renexa at that point. So, and that can kind of be applied to multiple situations, other comorbidities, because it's not really going to affect the blood pressure. It's not really going to affect the heart rate. It's not contraindicated in patients with left ventricular dysfunction or anything. So it can really be like sort of a third line or fourth line add-on for any of these types of things.
Yep. So all that we've talked about so far with chronic coronary syndrome has been to address that first goal, which was treatment or prevention of the actual anginal episodes. The other goal is to prevent long-term complications like heart attack, MI, stroke, that sort of thing. So there are instances where we will need to use aspirin therapy or antiplatelet therapy to try to prevent that from happening. So it can be used as secondary prevention. Aspirin can 75 to 162 milligrams a day. For patients who have diabetes and a history of atherosclerotic cardiovascular disease, that would be a pretty strong indication. You could consider aspirin therapy for primary prevention with patients who have diabetes and are at increased risk for cardiovascular issues. There's kind of a risk versus benefit thing, a discussion with the patient because of the increased risk of bleeding. So obviously, have we done an episode on like aspirin primary prevention and like all the different things that have come out?
I think we've touched on it a little bit, like the Ascend trial and all that.
Yeah, so obviously aspirin for primary prevention has been used for a really long time, and it seemed to go back and forth about the recommendations regarding that and whether it was beneficial or not. The age, when to do it, in these specific situations, blah, blah, blah. So there was, like Mike mentioned, the ASPRE trial, the ARRIVE trial that showed no cardiovascular benefit with aspirin for primary prevention, but had an increased bleed risk. But there was the ASCEND trial, which was aspirin for primary prevention in patients with diabetes, and there was a reduction in cardiovascular events over a 7-year period with a number needed to treat of 91. And then there was also an increased major bleed risk in that instance same period with a number needed to harm of 111. I remember when I was in school, the recommendation was like over 60 years, or maybe over 50 with a 10-year life expectancy and all this kind of stuff. Like, it was really strange, the ones that we would consider. And then like diabetes, it was kind of strange, but yeah.
Yeah, it's definitely changed a lot. The U.S. Preventive Service Task Force has updated their stuff, I believe.
Yeah.
So, real quick, I wanted to, because I didn't mention this, I want to make sure we put it out there. AJ, will you flip to my screen so you can kind of see? This is the table from the European guidelines to kind of break down like the different combo options and stuff. But a couple of things I did want to not forget to mention is, if you have a beta blocker on board with left ventricular dysfunction, if it's the comorbidity, start with a beta blocker. The reason why, potentially you're adding on the long-acting nitrate as opposed to a calcium channel blocker, one, you absolutely can't use a non-dihydro calcium channel blocker in a reduced ejection fraction situation. And then if you're thinking like outcome data and whatnot, patients that have heart failure, it's limited, and it's in combination with hydralazine, but there is some limited data with isosorbide, dinitrate, and hydralazine combo. So I'm assuming that's kind of why they lumped that as one of the options, because it's probably the calcium channel blocker is not going to do the dihydro calcium channel blocker like amlodipine is not really going to do anything to benefit the heart failure. So maybe their thought is that the long-acting nitrate could be, or the ivabradine would be another option, because we know that reduces hospitalization and heart failure. And then with the big thing though was just making sure you don't combine the non-dihydros in patients with heart failure or with ivabradine or anything like that.
Right.
So we're gonna cause some issues.
I did want to mention one more thing about aspirin, is that you will find places that recommend primary prevention in this instance, even without diabetes, in the instance of chronic coronary syndrome because of the coronary artery disease. So the guidelines do reference that. They say aspirin 75 to 100 may be considered in patients without a history of MI or revascularization, but with definite evidence of coronary artery disease on imaging, which might be our patients here, chronic coronary syndrome with definite coronary artery disease on imaging. They don't give it the highest level of recommendation. It's like a 2B with a C quality level of evidence. So it's not a strong recommendation that they give, but like, for instance, the up-to-date authors recommend that in this instance. So you'll see that.
Did we talk about clopidogrel or anything?
No, we haven't yet.
So the other potential thing you may see is patients who maybe they're candidates for aspirin therapy, especially if they've had a previous MI, revascularization, what have you. But maybe they have an aspirin intolerance or whatever the case may be. Clopidogrel could be a potential option as an alternate therapy to aspirin. Also, if the patient has a history of like PAD or history of some sort of ischemic stroke, TIA, something along those lines, then clopidogrel could potentially be used in preference to aspirin as well. But that's kind of low quality of evidence compared to some of the other recommendations. It's a 2B as well. And so just one of those things that if you see a patient on long-term clopidogrel or any of the other antiplatelets like that, that may be the thought process behind it.
2B or not 2B. They do also mention the use of proton pump inhibitors to prevent the bleed risk or to lower the bleed risk. So they give a strong level of recommendation for using a proton pump inhibitor with patients using aspirin as monotherapy, dual antiplatelet therapy. In the instance of Plavix, there's that whole thing about the interaction with proton pump inhibitors and clopidogrel. So whether or not that's like matters much, what do they recommend? Pantoprazole to be used with clopidogrel just to be safe or whatever.
2C19 interaction and all that.
Right. So yeah, you'll see that too.
Good stuff. So anything else we got to cover?
That's chronic coronary syndrome.
Basically. AJ, I want you, will you pull up my screen real quick? So real quick, I want to just make sure I thank our sponsor, Pearls. This is just an example of one of their charts. This is their diabetes treatment algorithm from 2022, and it kind of just walks through the steps of various treatment options based on comorbidities and all that. It's basically based on the ADA guidelines, but in a much more aesthetically pleasing to the eye format, I feel like. But he's got some great algorithms. If you haven't downloaded Pearls, then make sure you go to the URL pearls.com/coreconsultrx. You can get a free, membership, and you'll have some limited access. You'll get some free charts to download. And basically, if you like the app, you feel like it's beneficial, then you can upgrade it and get access to all of the content. But they're adding stuff all the time. They've been a great help to us. Kind of has been a sponsor for us for almost over a year now, I guess. And they've been great to work with, and their app has grown a tremendous amount in the last year. So definitely check it out. Throw them some support for supporting us. And don't forget, if you are a member of freece.com, then go to the link in the show notes. It'll take you to the post-activity test for this episode, the password, which we didn't mention in the beginning.
I was going to mention that because I realized I forgot.
It's good because I wanted to make sure you listen to the end this time instead of you cheaters that you just get the password and then cheat on the exam. No, I'm just kidding. Coronary is the password, all caps, CORONARY, all capital letters, and that'll give you access to the post-activity exam if you are an unlimited member holder.
Yes.
If you don't have that,
won't work.
You need to register.
You get your life together.
Exactly. Correct your path. But yeah, so check that out, get your credit. Also, if you want more like lecture style podcasts, make sure you check out the Patreon. So patreon.com/coreconsultrx has basically lectures that I do for my PA students. It's all pharmacotherapy, pharmacology, and I try to update them pretty regularly on there. So thanks to everybody who's been signing up for that lately. Really appreciate that. That helps us out a lot. So that link will be in the show notes as well. If you have any questions or comments, concerns for Cole, myself, or our friend AJ back there working the cameras, emails will be in the show notes. You can reach us on the social media platforms. Send us an email, send us a text. There's a number in the show notes as well. We'll do our best to get back to you as quick as we can. I know we're not always the best at that sometimes, but there's only a couple of us, so bear with us. We'll get back to you as quick as we can. And above all, thank you guys so much for listening. I hope you're enjoying the podcast still, and we'll see you guys in the next episode. Y'all have a good night.